Welcome to this explainer where we are going to completely demystify hair loss. Today, we're building a clear, evidence-based clinical framework, literally the exact same one used by top dermatologists. Because look, hair loss is incredibly common, but the underlying mechanisms, they can be surprisingly complex. By the time we wrap up today, you're going to have a solid grasp on the true pathophysiology of why we lose hair and exactly how medical professionals tackle diagnosing and treating it. So let's get into it. Before we start diagnosing anything, though, we need to look at one very important number, 100 to 150. That is the number of hairs a completely healthy person naturally sheds every single day. I'm pointing this out right off the bat because it's totally normal, and it establishes our biological baseline. If you have long hair, seeing 150 hairs clustered in the shower drain can look absolutely terrifying, but it's really just the natural turnover of your scalp. Today, we're focusing on what happens when that loss crosses the baseline into true medical alopecia. Okay, here's our roadmap for the day. 1. The biological baseline. 2. The Great Divide. 3. Common types and etiology. 4. Diagnosis and clues. And finally, 5. Treatment and management. Starting off with Section 1, the biological baseline and the normal hair cycle. To really understand what goes wrong in alopecia, you can't just think of the hair follicle as a pore. You've got to think of it as a dynamic little mini organ that cycles through very predictable seasons. It all starts with the anagen phase. This is a massive growth period lasting anywhere from 3 to 8 years. At any given moment, about 85% of your scalp is just hanging out in this active state. Then, the follicle shifts into the catagen phase, which is a super brief transition, only about 3 weeks. Finally, we hit the telogen phase. That's a 3-month resting period, where the hair is fully formed but totally inactive. And this resting phase naturally ends in shedding, just to make room for the new anagen hair. Now, this brings us to a frankly wild fact about scalp biology. Normal hair density can actually be reduced by 50% before thinning becomes clinically obvious to anyone else. Think about that for a second. I really want to highlight this because it validates the very real, often hidden distress that patients feel early on. By the time someone else finally notices your hair is thinning, you might have already lost half of your overall volume. It really underscores why understanding these early physiological shifts is absolutely crucial. Moving right along to Section 2, the Great Divide, scarring versus non-scarring alopecia. This is the primary fork in the road for every single dermatologist. The absolute crucial point here is distinguishing between scarring alopecia and non-scarring alopecia. And it all boils down to the stem cells located in the upper part of the hair follicle, an area we call the bulge region. In scarring or cicatricial alopecia, things like lupus or severe infections trigger an inflammatory response that permanently wipes out those stem cells. The hair factory is basically demolished and replaced by a fibrous scar. But on the flip side, in non-scarring alopecia, the hair follicle stays intact. The factory might be temporarily shut down or malfunctioning, sure, but the machinery is still sitting right there. And that means spontaneous or treatment-induced regrowth is entirely possible. All right, Section 3, common types and etiology of non-scarring alopecia. So, now that we've established our main categories, let's round up the usual suspects behind non-scarring hair loss. We can cleanly slice this into 2 distinct visual presentations, diffuse and localized. Diffuse conditions thin the hair out fairly evenly across the entire scalp. This includes things like Telogen effluvium and androgenetic alopecia, which are typically triggered by systemic stress, hormones, or genetics. On the other side, we have localized non-scarring alopecia. This is where hair falls out in distinct, circumscribed patches. The classic examples here are alopecia areata, driven by an autoimmune attack, and tinea capitis, which is triggered by a fungal infection. Let's zoom in on telogen effluvium for a second. Interestingly, this isn't technically a disease itself, but rather a symptom of a massive shock to the system. Major life events, childbirth, a severe illness, a drastic crash diet, or just extreme psychological stress can literally shock your hair cycle. It forces a huge percentage of those actively growing hairs prematurely into the resting, or telogen phase. And remember how we said the telogen phase lasts about 3 months? Well, because of that delay, the massive synchronized shedding doesn't actually hit until 2 to 4 months after the stressful event. So the trigger is way in the past, but the biological fallout happens months later. Next up is androgenetic alopecia. This one affects both men and women. The etiology here is basically a genetic sensitivity to circulating androgens, specifically dihydrotestosterone or DHT. What happens is an enzyme called 5-alpha reductase converts testosterone into DHT. That DHT then binds to susceptible follicles and just relentlessly shortens their growth phase over time. In men, you usually see this starting at the frontotemporal areas and the vertex. In women, it usually presents a bit differently, often as a diffuse widening of the central part, sometimes referred to as a Christmas tree pattern.
Looking at the clinical presentation here, you can clearly see how distinct these visual patterns are in practice. From those sudden, distinct circular patches of alopecia areata to the diffuse thinning of the androgenetic patterns we just talked about, all the way to the inflammatory destruction you see in scarring varieties. These visual manifestations are the very first clues a medical detective uses to navigate that great divide.
Which brings us to Section 4, Diagnosis and Clues. How do we clinically evaluate this? So the naked eye isn't always enough, right? How do doctors actually tell these similar conditions apart when the presentations start to blur? Enter dermoscopy. This is where doctors use a handheld lens with built-in magnification and polarized lighting to look deep down at the epidermal junction. It's fascinating stuff. In alopecia areata, they're looking for pathognomonic exclamation mark hairs, literally hairs that taper at the base, which is a massive red flag for an active autoimmune attack. They might also spot cadaverized hairs, which basically look like tiny black dots where the hair just broke off right at the surface. Conversely, if a doctor uses a dermatoscope and sees a complete loss of follicular ostia, meaning the pores themselves have completely vanished, well, that's your definitive diagnostic sign of a permanent scarring alopecia. Beyond that magnifying glass, the clinical toolkit gets super specific. Getting a thorough medical history to identify a past trigger is paramount for telogen effluvium. If they suspect a fungus, they'll scrape the skin for a KOH prep to hunt for dermatophytes. But listen, if a scarring alopecia is even on the table, visual inspection just isn't going to cut it. Doing 2 4mm deep punch biopsies becomes absolutely essential. A pathologist will section one vertically and the other horizontally. This allows them to examine the deep follicular architecture and see exactly where those inflammatory cells are attacking.
All right, our final section, Section 5, Treatment and Management, focusing on targeted approaches.
Once the detective work is fully complete and the exact mechanism is identified, the entire focus shifts to recovery. And we do this by mapping specific evidence-based treatments directly to their biological targets. For androgenetic alopecia in men, oral finasteride actively steps in to block that 5-alpha reductase enzyme, lowering DHT levels, while topical minoxidil stimulates growth. For women dealing with the same condition, anti-androgens like spironolactone are often deployed. And for those localized autoimmune attacks and alopecia areata, high-potency topical or intralesional steroid injections are used right at the site to calm down the T cells that are mistakenly attacking the hair follicle. Now, here is some genuinely reassuring data. Despite how severe the immunological attack in localized alopecia areata can look, the stem cells themselves are rarely destroyed. Because of that, a whopping 80% of patients experience completely spontaneous regrowth in any given patch within just 12 months. The human body's natural recovery capability, once that localized inflammation finally subsides, is just incredibly robust. However, to keep things fully impartial here, we do have to acknowledge that alopecia areata is highly dynamic and unpredictable. There are specific prognostic markers that warn dermatologists a patient might be in for a chronic, difficult course. If the onset happens before puberty, if there's a strong family history, or if the patient has associated autoimmune diseases or rapid progression, these factors tell the doctor that the patient might face persistent loss, which can sometimes evolve into alopecia totalis, or the loss of all scalp hair. Which leaves us looking squarely at the future. Recent evidence heavily points to the JAK pathway in the pathogenesis of these autoimmune attacks. As our understanding of this biology deepens, it leaves us with a massive question. With the highly unpredictable nature of autoimmune hair loss, will these emerging, highly targeted JAK inhibitors become the ultimate key to completely reversing severe, chronic alopecia? It's a cutting-edge frontier in dermatology, and the science is moving incredibly fast. Thank you so much for joining me on this explainer today. Keep questioning, keep learning, and I will see you next time.